Hi, it's Dr. Centeno, and welcome to You've Got the Power and my Facebook Live. Again, I've moved the Facebook Live from Friday to Sunday. So we're now at Sunday mornings at 9 a.m. Mountain and 11 Eastern, 8 a.m. Pacific. So trying to get more engagement. Someone told me if we moved it to Sundays, we'd get more patients on here. So the goal is to answer patient questions. Hence, more patients equals more questions. Today, we're going to talk about some really interesting stuff about the cervical pelvis. It sounds kind of nonsensical, but I saw that term recently, and it's something that we've been doing for quite a while. And I think that many physicians are not aware of. And that is that your shoulder area, obviously, and your thoracic spine supports your neck. And so loose joints in this area can be a problem for patients with cervical instability or cranio-cervical instability. So we're going to go into that today. Then we'll give everyone an opportunity to ask questions. You can ask questions about this topic or really about any topic at all. So again, for those of you just joining us, we'll be talking today about the cervical pelvis, or really what supports your neck. And obviously that becomes important when there's any kind of instability in the neck. And also how a doctor might try to determine whether or not you've got issues with that base of support, and then how a doctor might try to treat those issues, because this brings up this concept that there's obviously instability in the neck, but if there's instability in the supporting system for the neck, that could be a problem as well. So let me go ahead here and share my screen. And then we'll go and do a quick presentation here. Okay, so again, this is the new time for Facebook Live. We're at 9 a.m. Mountain, 11 a.m. Eastern on Sundays. So topic today is, what is the cervical pelvis? Why the joints in your shoulders serve as the base of support for your neck. And it's really interesting. I typed into ChatGPT this concept, and I got this great image back. I thought it really, really nailed it. Really nailed what I was trying to show, and that is that you may know that your pelvis is the basis of support for your lumbar spine. A lot of patients are taught that, hopefully. But you may not know that this whole area up here is going to be the base of support for your neck. So like, comment, share, subscribe, depending on where you are. If you're on YouTube, Facebook, that's how we get this out to more people. That's how more patient questions come in. And really, this show is about questions, right? I give a short presentation, but then there's ample opportunity for questions, because I find that we learn best by hearing answers to questions. So the pelvis acts as the base of support for the spine. Maybe you've heard that. You might have heard that if you have SI joint instability, that's kind of like the floor of the house. So as I always have told patients about it, your pelvis, your SI joints, that's like the foundation for the house. Then you've got the walls for the house. That's like your lumbar spine, thoracic spine. Then you've got the roof of the house. That's like your neck and your head. So obviously, if there's a problem in the foundation, if the foundation is off, then the rest of it's going to be off, and you're going to have problems. You're going to get cracks in the walls, cracks in the ceiling, etc. So I think we can all understand that. And this is the reason why SI joint instability can be such a problem, because we've seen lots of our CCI patients, for example, come in with chronic SI joint instability. And if that patient can tolerate it, we'll try to treat that SI joint instability at the same time. Now, sometimes they can't. Sometimes we have to treat it separately. Now, is there a similar setup for the neck? So one of the reasons why I love this ChatGPT image was that, you've got the hips on either side there, but those could very well be the shoulders. So as you know, you've got a neck. That neck sits on the thoracic spine. There are ribs coming around, and there are two shoulders there. And it's the SC and AC joints and upper ribs that create this systems of support for the neck that's analogous to the pelvis. Now, I've been checking SC and AC joints, anyone that's been a patient of mine, especially my CCI patients, for a long time. I've been treating those joints for a long time when I find them to be unstable. But I find that it's not really common for people to check those because, I'll see CCI patients that have seen 10 of their doctors and no one's ever checked their SC or AC joints because we'll have that discussion. So the muscles anchor in this neck pelvis system, and that's going to include things like the scalenes, which help to stabilize the neck, the upper trapezius, the sternocleidomastoid. They all anchor in this system of the ribs, the SC, the AC joints, the clavicle. Now, I always use this analogy for patients so they can understand why they might be having a hard time, for instance, lifting their arms over their head if their neck is unstable. And I always tell them, if you're standing on the shore and trying to lift weights, that's one thing, right? You know how much weight you can lift. But if I were to put you balancing in a rowboat and you were to try to lift the same weight, because you don't have any intrinsic stability on the floor, the boat's doing this every time you're trying to lift, you're going to be able to lift less. Or it's going to be twice or three times as hard to lift the same amount. And that's why one of the tests I'll perform for CCI patients is, some of my CCI patients will struggle to lift their arms, and then I'll hold their head. And as I hold their head and provide that artificial stability, they can now lift their arms. In fact, I call that a head hold test. You may want to try it. And it's the same idea here. I took them from the rowboat, meaning they didn't have the intrinsic stability as they were trying to lift their arms because these muscles, these trap muscles, anchor in the head. And I put them on shore now, from the rowboat to on shore. Well, it's the same thing here. If you don't have intrinsic stability in these SC-AC joints, and these muscles are also pulling against those SC-AC joints, it's like trying to lift weights in a rowboat. So any exam for neck instability or CCI needs to examine the shoulder and chest joints for instability. Not commonly done, but it needs to get done. Now, if the neck pelvis joints are unstable, things like the rib facet joints and the upper cervical spine, the SC joints, the AC joints, we use precise ultrasound-guided ligament injections in those areas. Now, sometimes our patients can't tolerate that. Most of the time they can. So it's pretty frequently, or you'll see pretty frequently in my treatment of CCI patients, I will be treating an SC or AC joint if that joint is loose on exam. So in summary, there's a neck pelvis made up of the SC, AC joints and ribs. These joints support the neck muscles that anchor there. When those joints become unstable, this can make cervical instability or CCI worse. Hence, those joints in this shoulder area, SC, AC, rib facet, should be checked. And if there's any instability there, those joints should be treated with the neck ligaments. Okay, well, that's the basic thrust of what I wanted to talk about today. And that is that house analogy, right? You've got the foundation for the house, the walls for the house, the roof of the house, and it's all got to function to support the trusses and the roof, if you will. Okay, let's see if we've got some questions. Looks like we got a bunch of questions here. And we'll start to take those. Let me get rid of the share. Rishi, is a 36-hour fast safe to do before PICL? Yeah, it shouldn't be any problem. I think that if you were malnourished to begin with, that could be a problem. But assuming you can eat normally, and you're otherwise normally nourished, it shouldn't be a problem at all. Hi, Dr. Centeno, if OPLL ligament has been overworked, well, OPLL is ossification of the posterior longitudinal ligament. Maybe we're talking about the posterior longitudinal ligament. Stretch lax, this allows the disc to continually bulge out as it can't perform its seatbelt function, causing the body's inflammatory response. I'm not quite sure if there's a question somewhere in there or not. Maybe there's a question down below. Regenexx, spinated advance by John Gardner. How many spinal epidurals of PRP typically are needed to heal a bulging disc at 5'6"? Would you say 2 to 3 to do it? Yeah, so the goal isn't so much to heal a bulging disc as it is, bulging discs are common. If we were to take 100 people off the street who are, let's say, older than 40 years of age, we'd see a lot of patients with bulging, a lot of people with bulging discs and not many people with symptoms. So they don't really always cause symptoms. That's the fiction part of this. Very important to realize that, again, having a bulging disc is pretty normal as we age. It's like wrinkles. So you don't necessarily need to get rid of the bulging disc, because bulging discs are as common as wrinkles. What you need to do is to calm down the nerve and prevent the nerve from getting irritated, which would be usually why we would treat that level. If you were trying to get rid of the bulging disc at C5-6, that would be more using culture expanded mesenchymal stem cells to do that. Rishi, I'm in so much pain with axial neuralgia. Can the second PSCL more aggressive and hit many more structures? I understand the first PSL is being approached conservatively as you don't know how the patient will respond. But is there a different approach the clinic takes for second PSL? Is not certainly sensitized, and my recovery from PSCL1 was 2 to 3 weeks. Certainly possible to get more aggressive, Rishi. We'll take a look at all of that, and we'll see what it all looks like on a hands-on exam. I only have 3 symptoms, which are axial neuralgia, trigeminal neuralgia, and bobblehead, which are incredibly debilitating. What specific ligaments can be targeted if someone has had a difficult time holding their head up? Yeah, that's not specific enough to get to specific ligaments. So we'll have to look at the imaging and make some decisions there. Also, we'll also have to see if there's true trigeminal neuralgia or just TMJ. I see a lot of patients with TMJ who claim they've got trigeminal neuralgia, and it's just garden variety TMJ. Simon, also can mesenchymal stem cells help with myelomalacia? Is there something you offer? No, mesenchymal stem cells can't help with myelomalacia. Rishi, what is with the epic? Oh, EPICL maybe. Is the alar ligament still injected above and below? Still injected from above into the body of the ligament and then below. Regenexx been advanced by John Gardner. How many millimeters would you expect in reduction of instability per PICL treatment? Example, if someone has 4 millimeters of C1 overhang, would you anticipate about 4 treatments? Fewer than that. So in responders, I would say 2 to 3 or less if we're getting that somebody within that first year of their problems. So if we're getting someone in that first year, 18 months of their problems, then really we're only talking about a single treatment. Charlotte, didn't mean to anger out trying to get volume. Gotcha. Could you show us proper lateral flexion for DMX? I had 2 PICLs. First DMX, I bent more whole neck. Second DMX, bent more at the upper cervical legs, keeping lower neck stable, 45% decrease in overhangs. So you want to get as much lateral flexion as you can, both from the upper cervical spine and the neck when you're doing a DMX. You know, some of the things to keep in mind would be making sure the head stays absolutely straight because it has a tendency to rotate. And that's not easy to do. Also, obviously, you have to get the image in the open mouth And that's not easy to do. So, the person doing the DMX should be constantly adjusting to make sure that you're not rotating your head and that your nose stays pointing straight. Then you've got an open mouth, and they're adjusting you this way and that way to make sure that we can see the corners we need within that open mouth. Brian, wondering if it's accurate, maybe telehealth call with you. Yeah, Brian, I'd have to look at your images to know. It's been advanced by John Gardner. Can dry needling help heal tendons to assist in healing CCI? No, I don't think that happens. I know that there's one provider out there claiming he can heal CCI through dry needling. We've been dry needling upper cervical tendons for 20 years, and we didn't cure any CCI during that time. So no, I don't think it works that way. Now you can get good short-term symptomatic relief that way because you can turn on some of the upper cervical muscles. So that's good. Or if you've got a very mild case of someone with very mild issues, and it's mostly proprioceptive due to problems with the suboccipital muscles, you can even cure those patients with dry needling. But when it comes to most of the patients we see for CCI, getting a PICL, you're not going to heal anybody that way. V cells are fiction. We really don't have any data that shows that V cells are real at this point. There was a good paper done on that. Probably about 6-7 years ago. I think it's on the blog. If you just type in V cells, it'll come up. Regenexx been advanced by John Gardner. What actually causes people with CCI to be unable to work out or run is that the muscles around the instability get so tight and tender, holding the head on, increasing symptoms. Yeah, so I think what we see with any instability, not just CCI, is you tend to see a flare-up from exercise. So let's take ankle instability. I had ankle instability before I got it fixed. I could tell you during that time, I became a connoisseur of different ankle braces. And what I noticed was that I could go out and do things like play basketball or run, but I would pay for it dearly that evening, a couple hours later, the next day. And what was happening is that things were moving around too much. I was young enough where I didn't have a lot of joint damage, but then the area which had gotten beaten up by that activity would swell up. Now, CCI makes it even worse because we've got all these nerves in there that are getting aggravated during that activity because the ligaments aren't stabilizing the area. So that's what causes things to get worse. Mark, last week, I think I heard you saying something IV stem cells causing an immune rejection response. I was wondering if you'd give us some more information about this. Asked me because we've seen an uptick in online patient groups from what I believe are possibly paid testimonials trying to convince patients to do IV stem cells. I'm grateful for the info you shared regarding the pulmonary first pass issue. Yeah, Mark, listen, you got to be very careful on Facebook. There are many, many paid, what I would call either patient salespeople. So basically, you've got patients who are getting free treatments by moving other patients into clinics. You've got some people posing as patients who are paid by these clinics to aggressively try to post very positive things about a treatment. So be very, very careful there. IV stem cells for CCI would be absurd. In fact, I just chastised a patient, I did a telemedicine on the other day. I don't know how many tens of thousands of dollars this guy's wasted by going down to Mexico to try to get IV stem cells for a CCI, but it was totally silly, meaning that, as you bring up, there's a pulmonary first pass effect. So that means that 97% of those cells that are going IV are going to end up in the lungs. And then some tiny percentage are going to get past the lungs. Then, obviously, since they're going IV, you would need a blood supply in order to take them to the injured area. Problem being that most of the things that we're talking about that haven't healed didn't heal because they don't have a blood supply. And they're unable to establish a blood supply. So those cells aren't getting to those areas. And then we get into the whole rejection issue. And that is, it used to be believed that mesenchymal stem cells didn't cause a rejection response. We now know that they do. So if you get someone else's stem cells and those cells aren't HLA matched, then your body takes those foreign cells out. So it's a little bit of a silly concept that you would try to use allogeneic, i.e. someone else's stem cells IV to treat your CCI. And I see a lot of patients wasting a lot of money doing this. In fact, this guy had also gotten an intrathecal injection, which is even more dangerous, especially done in Mexico. Guys, you need to be very, very careful. We've got the US standard of care, and even here, there's huge lapses for patients with CCI. But let's say just for general medicine, that's the US standard of care. The standard of care in Mexico is much, much, much lower, meaning that US physicians generally can't get licensed in Mexico. It's very hard to do. So the likelihood that you're going to find someone in Mexico who has that US type training where they're doing years and years and years of subspecialty training is very, very small. So there's all sorts of crazy reasons why you wouldn't want to go down to Mexico to get an IV stem cell treatment. But you bring up some good ones. Pulmonary first pass is a good one. Regenexx, it's been advanced by John Gardner. Does CCI cause muscle spasms in my neck, back, arms, and sometimes legs? Will correcting CCI cause spasms to go away? You know, John, I don't know. I'd have to look at you personally to render an opinion about that. For example, many CCI patients also have problems in their low back. So sometimes their leg symptoms are directly related to what's happening in their low back. They've gotten an MRI. Their MRI does have findings on it, but the reading radiologist didn't read it out. So it's kind of invisible. Brian, my right pelvis is lifted 8 millimeters. Any exercise recommendation? Again, Brian can't make that kind of recommendation online without doing a more thorough evaluation of what's going on, what's wrong with you. Rishi, PICL1 helped a bit with my terminal trigeminal neuralgia. However, for other symptoms, didn't provide relief, such as occipital neuralgia instability. Cause of this, I'm at a crossroads if I should go to occipital nerve decompression surgery for PICL2. So I don't have enough money for one of these treatments. I know decompression is not good for anyone who has CCI, but I'm not sure what to do here. I would recommend it for someone in my position. Yeah, Rishi, I don't really believe in occipital decompression in 99% of the cases, simply because you're destroying suboccipital muscles or some suboccipital muscles, which stabilize the head on the neck in order to decompress. There's no other way to decompress without destroying some of those muscles. Obviously, if you've got CCI, you need those muscles. If you take the muscles away, then you make the CCI worse. You know, listen, Rishi, one option is obviously to just come in and do some occipital nerve hydrodissection and leave it at that, or to try to get a local provider to do some occipital nerve hydrodissection and focus on that as the treatment. That might be less expensive. Brian, what would you recommend for one-handed farmer carries? Would you recommend? No, Brian, I don't give treatment advice like that just off of a short description of what's going on. It's been advanced by John Gardner. Is it accurate to say you get 0.5 millimeters of reduction of instability per round of PRP? So in my case, with 3.5 millimeters of instability, would likely take 7 treatments to feel better. Not quite sure which type of instability we're talking about there. If you're talking about translational instability in the cervical spine, then in my experience, you would get more reduction in instability per treatment than that, even with just something like prolotherapy. But I'm not quite sure if you're talking about that or C1C2 overhang, where we don't use PRP in a PICL, so it's a little, you'll have to clarify. Victor, in your experience, if patients do well with posterior PRP at C2 through C7 in terms of recovery, post-procedure pain, return of function, do they tend to do well with PICL recovery? Yeah, I think that tracks pretty well, meaning that most of the patients who have no problem tolerating most neck procedures really don't have a problem tolerating PICL. It's really the patients who would get something like posterior PRP, C2 to C7, and then they would flare for weeks or months. Those are the kinds of fragile egg patients who might have a hard time with PICL. Estimated advance by John Gardner, what actually causes people with CCI to be unable to work out. I think I got that one already. TO, would IV stem cells help with Crohn's disease? No. Yeah, IV stem cells are a scam, guys. A total absolute scam. Stay away from IV stem cells. There may be ways to treat stem cells with Crohn's disease. That's outside of my area of direct expertise. But IV would probably not be one of them because I think it's already been brought up. There's a pulmonary first pass effect. The only reason the clinic is offering an IV is because they don't have any expertise in how to treat what it is you've got. Now, perhaps there might be ways to use stem cells to treat Crohn's disease by using interventional radiology to get into the arterial distribution of the gut. That might be one way to do it. I'm not an expert in that area, but I can tell you an IV is a silly way to do it. And you're only being offered an IV because the clinic doesn't have any other expertise. And they can get an IV, someone to start an IV for $20 an hour. Whereas the guy who I just described, who would get into the arterial distribution of the gut to deliver stem cells, is going to run them $300 an hour. So again, they're offering an IV, not because that's the right way to do it. They're offering an IV because that's the cheap way to do it to maximize their profit. So it's a scam. So stay away from clinics offering IV stem cells, period. Unless you got a lung problem, they'll end up in your lungs. Brian, any way you can get involved? You need a salesperson or a patient advocate. No, don't use salespeople, but thank you, Brian. We're a medical office. Jing, hi doctor. I started messaging soon after the PRP injection and first time imbalance started in the 3rd weeks. Now the 9th week, I've been messaging for 7 weeks every day. My neck muscle ligaments are now very relaxed and weak. Can't support my head. Got worse for unstable and I walk feet. Yeah, Jing, I'm not quite sure what you're trying to describe. It sounds like you had a PRP injection somewhere. Someone said that they did the facet capsules. That's fiction. That just means that they did standard Hackett points. They called it facet capsules because they didn't really know how to inject the facet joint. So you got a little bit scammed there. I know you haven't been messaging me. So I'll put my email down here. Obviously, if I can help you, I'm happy to. So I'm putting the email that goes to my desk in the comments here. So drop me a line. I'm happy to try to help. It sounds like someone scammed you a little bit, claimed that they were injecting your facet joints from C0 to 7, really weren't injecting your facet joints from C0 to 7. I don't know. But I just put my email down there, and that's how you would reach out to me. You may have been trying to reach staff or something, and they didn't have any context for what it was you were trying to tell them. Brian, how's the study going? Will you publish soon? The randomized controlled trial, we are having difficulty recruiting because people don't want to be randomized to sham or placebo. Case study is going well. That will get out the door. AT, any experience of a scenario where a patient improves upon a PICL, afterwards is able to do and progress with curve correction, then returns another PICL with much greater improvements this time? Yeah, I think AT, you have been pursuing probably the most aggressive curve restoration we have seen, and I have supported that because seems like you've been threading the needle nicely between getting flare-ups and being aggressive. So you could be, an N of one when it comes to someone with high level disease who is pursuing curve correction that aggressively. I think it makes sense that you would do much better with PICL number 2, simply because you've been pursuing that curve correction and everything else under the sun. So I applaud you for that, because I think you're doing a good job of threading that needle between being too aggressive and causing a flare-up and being not aggressive at all. So we'll see how it goes. Megan, does the fact that it's been almost 10 years since the injury impact the ability for stem cell treatment to work? In what ways? Megan, if you could put what it is we're talking about stem cell treatment for, that would be great. If you're talking about cranio-cervical instability, it may make a difference in that you're not in that 12 to 18 month range, so you're probably not going to need a single treatment. Having said that, you're a lot like many of the patients we treat who are not in that 12 to 18 month range. If you're talking about something else, then let me know, because that would be a different answer. Melinda, I verified CCI via DMX and have severe triangular pain in the shoulders and nerve zaps and feel bobblehead doll, vision issues, jaw and mouth pain, and much more. Where's the workup for cervical pelvis instability? Linda, that's just a hands-on exam when you come in, having us look at the AC/SC joints, the upper thoracic rib cage, etc. So that's a hands-on exam to identify those. I would say in the CCI population I currently see, we're identifying, for example, SC or AC instability in probably a third of the patients that come through. And those patients are getting those joints treated concurrently with their neck. Liam, hi Dr. C, hope you had a great trip. With the EPICL, how many more injections the alar ligaments are you able to complete versus previous technique? Yeah, so I think the best way to describe it, Liam, is prior to EPICL, I would say we were getting the mid-substance of the ACL about maybe 50-60% of the time. And that's gone up to about 90-95% of the time. Now, we were doing a good job of getting the upper portion of the ACL, getting the lower portion of the ACL before EPICL, but getting the mid-substance has dramatically increased since we started doing that, or since I came up with that adjustment and technique to ensure that. Marcia, expert opinion on Dr. Agnes Stagisia offering PICL Hungary. She has not been trained by me at all. I do not approve of anyone else doing the PICL. In fact, this doctor showed up at my office one day, wanted to watch me do some procedures, which I allowed her to do. Those procedures were not done to train her at all. So I do not believe that she has the qualifications to do this procedure, or anybody else has the qualifications to do this procedure. Just not a good idea. There's too many moving parts in this procedure, too much to learn to be a see one, do one, teach one, which is what is happening here with this doctor. And hence, after this doctor came to my office, I no longer allow any physician to observe the procedure, because we really got burnt by this physician. And she's trying a see one, do one, teach one approach, which is inappropriate for this level of procedure, in my opinion. Jessica, how do you know if alar ligament is torn or ripped? I think maybe what you're asking is, how do you know if the alar ligament is torn in half and pulled back like a rubber band? That's pretty rare. We've only seen a handful of those out of thousands of times looking. Usually what you see 99.99% of the time in alar injuries is it gets stretched and everything is still together. Melinda, in your experience, have you seen CCI or cervical pelvis cause breathing issues? We definitely have, for sure, especially when there's involvement of that rib cage. Marcia, do you think CCI patients' brains are more prone to developmental burnout? Started studying languages 50 hours a week after PICL3 and became mentally burnt out for the first 3 to 4 months. How to recover? Studying languages 50, yeah. So, anytime you're recovering from something like cranio-cervical instability, probably doing anything intensively like that is going to be a problem. 50 hours a week studying languages, that's a lot. I mean, I'm studying a language right now, Italian, and I put in a couple hours a week. And sometimes that seems like a lot. Like yesterday, I did maybe 40 minutes and my head was going to explode because it's all new information. So I think you recover by backing off and letting things kind of calm back down. And then maybe next time, don't go at that quite so hard, meaning that that's a little bit like trying to run a marathon before you run a 5K. Liam, the EPICL helps significantly improve outcomes for type 2B patients. That's what I believe, Liam. We're just now starting to get our first 4 months patients back for my patients after I started doing EPICL. So far, so good. We'll know more in a couple months once more of those people come back and we get to see what happened with them. Ben Moses, can slipping first, second ribs cause tension and pulling of neck muscles resulting in atlas subluxation? I think so because, maybe not axis subluxation, but can cause certainly pulling through the scalenes, right? The scalenes, one of the scalenes goes all the way up, and or levator scap can do the same thing. So I think it's possible to see things like that happen, and it's one of the reasons why I brought up this whole cervical pelvis thing. Megan, yeah, great. So I think I've answered it correctly then. Opinion on invasive cervical traction efficacy for turning a patient could benefit from fusion as a last resort. Yeah, so I think as I've talked about before, Marcia, invasive cervical traction is a little bit of a two-edged sword, simply because you're offloading a lot of different things. And what I mean by that is that the concept, just so that people understand, with invasive cervical traction is you put a halo on someone's head, you put some screws into their skull in various locations, right? And then you pull some traction. And the idea was supposed to be that you would make some room for the back part of the cerebellum, and that would open up that area and they would feel much, much better. And indeed, in some patients that might happen. But the problem is there'd be a big false positive rate. And what I mean by that is that if you've got a painful facet joint at 0, 1, 1, 2, or 2, 3, it's also going to feel great. So you wouldn't know if you were dealing with an upper cervical facet problem, for example, or crowding at the back of the brainstem and a Chiari malformation. So that's the problem. It's a pretty non-specific test. And I think the other issue is that in medicine, we tend to be pretty compartmentalized, right? The guys that do surgery don't necessarily know so much about things like facet problems because they've never done a facet injection. They don't have that direct experience. So I think that's one of the issues there, is that compartmentalization is causing some issues. John, I know Regenexx does a great job tracking patients' recovery. What percentage of patients get full healing with PICL? Yeah, John, I think we've talked about that before. Recovery rate is about 7 in 10 for PICL. That's the number we've always used. That's the number the data tends to support. That means that 3 in 10 patients wouldn't get as much relief and might either decide not to do anything or go on to another type of treatment, usually surgery. About 7 in 10 would get enough relief where they're not doing that. So that's the same number I've always used, and it seems to be on track. My guess is that might go up a little bit now as more and more is getting dialed in. Things like EPICL, Candice is getting better dialed in, etc. Andreas, why are some IJV compression asymptomatic and some symptomatic, even with the same amount of compression? Is there a way to know if compression has caused symptoms, ultrasound velocities? Yeah, Andreas, you bring up a great point that I want everyone to stop and listen to, because this is critical. Patients have it in their head that if someone sees something on an imaging study, it must be causing their symptoms. That is absolute positive fiction. Let me say that again. Patients have it in their head that if someone sees something the least bit abnormal, in quotes, on their imaging studies, that must be causing their symptoms. That is absolute positive fiction. Now, I understand why desperate patients would latch onto anything they can. So I get it. However, we also need to make sure we're careful. So IJV compression is a great example of that, right? We know from carotid imaging studies where they're trying to see if someone has a blocked carotid artery, and they're trying to see if they should operate on that carotid artery. Completely different symptoms than IJV compression. That compression of the IJV is super duper common in patients that don't have symptoms of IJV compression. How common is it? 1 in 3. And in fact, for severe bilateral compression, it's 1 in 5. So how come those people don't have symptoms? Well, it's the same answer that we see all the time in medicine, right? We can take a lumbar MRI or cervical MRI, see disc bulges, nerves that look like they're getting irritated, and someone has no symptoms. And the reason is that really what we're dealing with here is a multifactorial, multivariate system that causes symptoms. So in the case of IJV compression, it may be the intermittent compression from instability is worse than chronic compression. Why? Because the chronic compression you can compensate for. The body is great at growing collateral circulation around compression. And you may not be able to do that as readily when something's only getting compressed intermittently. So there's one example why they may be completely different. But be very, very careful, because we've got providers out there throwing an ultrasound machine on, which is not even a good way to measure IJV compression, and claiming and getting people all excited about the fact that they've got IJV compression, when we many times are probably just looking at something they had well before they had any symptoms at all, and something that has nothing to do with why they have symptoms. So great job bringing that up, Andreas, because it's a great point for us all to understand that we've got to be careful when we see positive imaging findings. And I get personally why someone would want to grab onto that finding and say, aha, I found what's wrong with me. But be careful. It may not be what's wrong with you. It may just be a normal variant finding. Teal Kyles, could you please direct me in the right direction for help with Crohn's disease? It's for my 12-year-old daughter, currently treating her with annual infusions. Could you please tell me this live, or should I mail you? Teal Kyles, I'm a big believer in expertise. It's not my area of expertise. I'm not a GI doctor. I don't pretend to be one. So I don't know who to send you to, who's the super expert, who might know how to use stem cells to treat Crohn's disease. Crohn's disease, I just don't know. So I apologize for that. But, it's very important that you speak to an actual expert in Crohn's disease, not some guy like me who doesn't see patients with Crohn's disease all day. Jessica, how is it to see alar ligament on standing upright MRI, and why do most radiologists, neurologists miss this? A standing upright MRI wouldn't be the best way to image an alar ligament, period. The best way to image an alar ligament would be with a 3 Tesla MRI closed bore with a head coil. So upright MRI is not a great way to image alar ligament, never has been, never will be, because you just don't get as much punch behind the image as you would with a closed bore magnet and a head coil. Now, one of the things that you can do on standing MRI is you can do things like look at CSF flow, for example. You can do flexion and extension and try to see if things move around too much. Those are all areas where standing MRI can excel, but structural imaging is not an area where standing MRI would excel. Ben, any insight into why when my psoas and outer hip muscles on my right side gets tight, it generates a pulling all the way up to the right side of my head? Ben, I don't know. I could postulate that perhaps you're getting some rotation in the thoracic spine, or I'm sorry, in the lumbar spine, because remember the psoas attaches to the transverse process. So that's going to pull that part of the spine forward, and perhaps you're feeling that all the way up. That's one option. So something to think about there. Ben, someone in Oregon that can do ultrasound rib diagnostics like your office does? I don't. The rib cage and thoracic spine is a pretty specialized area, regrettably, meaning that very few doctors do a lot of work in the thoracic spine and rib cage. So I don't see a ton of expertise out there in that area. I do a lot of it. Some of the doctors in my clinic do a reasonable amount of it. But in most clinics, physicians conceptualize it as a neck problem or a back problem, and then there's this no man's land in between. Why is there no man's land? The procedures in that area tend to be more difficult because the lung field is there, and you could potentially puncture a lung if you're not careful. So I think it's kind of caused most doctors just say, there's the neck, there's the back, and then there's this thing in the middle. I don't want to deal with this thing in the middle because there's lungs there. KS, do you think dental bite jaw influences atlas alignment? I did Invisalign, noticed wearing retainers more often to keep things stable helps. Yeah, I think there's a definite relationship between what's going on in the jaw and what's going on in the upper neck. We've seen that for many, many years. So it's not surprising that you might feel better stability with better jaw alignment. Brian, can nicotine affect PICL recovery? Nicotine poisons everything, Brian. Poisons your heart, poisons your brain, poisons recovery and healing. So yeah. I would get off of nicotine if you're going to do recovery from anything, let alone these kinds of procedures. Marcia, could you provide some insight on how CCI could cause high fatigability in limbs? Yeah, so Marcia, I think if you look at that picture that I had up before, I'll see if I can maybe put it up again here. See if I got it here. Hold on a second. Let's try to get just that window. So this is the example I usually give. So let me give you a concrete example. Someone walks in my office, right? I say, can you put your arms over your head? And they're struggling like this. They've got CCI. They just can't do it. That's as far as they can go. I then physically hold their head and prevent it from moving. And I ask them to do the same thing. And their arms shoot up. Oh, wow. Yeah, now I can lift my arms. What just happened? The first instance, without me holding their head and with their CCI fully causing issues, is like trying to lift weights on a rowboat. They don't have stability in the upper cervical spine, and all these muscles are pulling on the upper cervical spine as they're lifting their arms. So the upper trap muscles are double working. They're trying to stabilize the upper cervical spine as well as lift the shoulders. They can't do it. So it's like trying to lift weights on a rowboat. Very hard to do. Then I go ahead and I stabilize their cervical spine. And now their upper traps only have to lift their arms. And it's easy for them to do. So in the same way, I think that's probably why you're seeing high fatigability in your limbs. Hopefully that explanation helps. Sonia, hi, Dr. Centeno. Is someone who has abnormal lateral overhang DMX indicating alar ligament laxity? What have you found to be the most common cause of occipital burning, pain, and pressure headaches? I did not receive an occipital nerve resection during my PCL, so assume those occipital nerves are asymptomatic. Yeah, usually the burning pain can come from a lot of different areas. It can come from irritation of the C2 dorsal ganglion at the posterior aspect of C1, C2. It can come from any of the upper cervical joints, which all refer pain into the head. It can come from swelling in the dens bursa from too much upper cervical movement. So yeah, if we saw that there were irritated occipital nerves, we would have done an occipital nerve hiatal dissection, assuming we felt that you could take that, meaning that assuming you weren't in that fragile egg type patient where we were dialing things back on purpose and trying to get a sense of how you would respond. Adina, I think 1/3 ratio of IJV compression is based on studying people actually having health issues regarding CT angiography. Is there any data on the incidence of this in healthy subjects? Well, they're having health issues for sure. So that means it's an older population, maybe in their 50s or so. I have not seen a study in healthy subjects, but I think, Adina, it's still the same point, right? The vast majority of patients I'm seeing for CCI are not healthy subjects. They've been ill for quite some time. They've had every test in the book. So my CCI patients are much more like those people getting CTs than the normal healthy 20-year-olds walking around on the street, for example. Victor, thank you for the real talk and imaging findings. Case in point, I had left-sided MRI findings, but all symptoms were right-sided. It was ignoring that finding that led me down the right path. Yeah, Victor, and we see this all the time. I'll give you another example. Super common as people age to get lower cervical degenerative disc disease, right? Lots of people get it. It becomes about 1/3 of people after age 40. If we then go to people in their 50s, we're now up to about 40%. If we go into the 60s, we're now up to about 60% of people have lower cervical degenerative disc disease. I can't tell you how many MRIs, DMXs have been taken showing lower cervical degenerative disc disease, and someone's got upper cervical symptoms. But everyone focuses on the bright, shiny object. In fact, I call it the bright, shiny object syndrome, which is in the medical care system, we tend to focus on the bright, shiny object. In that case, it's the lower neck. Even though someone might be walking in with obvious upper neck symptoms, that's ignored. And what's paid attention to is the otherwise normal degenerative findings in their lower neck. So thank you again for bringing that up. Flappy ragdoll, gotcha. Levon, if IJV compression is causing symptoms, how much a candidate would it be if IJV compression is due to CCI? Can stenting be contraindicated? I.e. unstable atlas can crush stent. Yeah, Levon, if you've got intermittent IJV compression from instability, thing that makes sense is try to fix the instability. As far as stenting is concerned, that's much, much more invasive than a PICL procedure. So you wouldn't want to consider something like that until you'd failed something like a PICL procedure. Again, remember the old adage that I talk about a lot, and that is that we keep patients safe by doing the least invasive thing we can do that makes sense. And if that fails, then we do the next most invasive thing. If that fails, then we do the next most invasive thing. That's how you keep patients safe. So in this case, you're talking about leapfrogging that, right? You're going to get a stent in your IJV, which is much riskier, and then see if the PICL helps. That's backwards. Garcia, well, thank you for the robot explanation. That makes a lot of sense. Upper traps being overworked would cause domino effect in limbs. Yep. Yeah, and I like that. That's actually another ChatGPT image. Did a really good job on that one. I think I told it to give me a picture of a man lifting weights on a rowboat because I always talk to patients about that one, but obviously I have no image of it. You really can't Google that image. It doesn't really exist. KS, does anyone have good pillows? I'll let you source that out to patients. Jessica, is it true Dr. Williams and I inject C0, C2 posterior approach? Jessica, we don't recommend any site outside of Colorado does upper cervical C0 to C2 injections. I think Dr. Williams has now moved his practice to Grand Cayman. That's my understanding, but we don't recommend any site outside of Colorado for C0 to C2, just because in order to have the amount of cases you need to be expert in that area, it just doesn't exist outside Colorado. I wish it did, but it doesn't exist. Marcia, is there a point where some measures, i.e. overhangs, get better and that triggers the tight neck muscles to relax overnight, or a gradual thing? I would think more gradual thing. Very rare to hear overnight kind of changes, really with anything. AT, can CCI cause changes in occlusion, for example, subclavian muscles? Yes, we see that all the time, for all the reasons I talked about before. Megan, do you have suggestions on reducing occipital nerve pain for CCI in between patient treatments? Yeah, certainly you can do simple things. Simple things would be direct myofascial release of the suboccipital muscles can oftentimes help. Obviously, postural things to try to offload those upper cervical muscles, working on curve correction to try to offload the upper cervical muscles. There are little home devices you can get that replicate little fingers. I think it's called an occipivot. I haven't seen one in a long time, but I think they're still available, that you can lay down on and do some self-massage in that area. Those are just a couple of ideas off the top of my head. AT, thanks for your time, Doc. Happy to help. Listen, AT, I think you're doing a great job, like I said, threading that needle, and you're aggressively pursuing all this stuff, so I'm excited to see what happens. Zigzag, Dr. Centeno, are there specific neck vertebrae that influence vision? I have CCI diagnosed via DMX, and I feel like I can't control my gaze, my vision normally. Yeah, I would get the CCI book that I wrote, because I think you're bringing up a great point, but let's go over that point so that everyone can learn. The upper cervical spine is directly linked into your vision. And in fact, your inner ear, your eyes, and your upper neck are all linked together. And it makes sense why they would be, right? Let's say it's 50,000 years ago, and I want to try to throw a spear to hit some animal that's moving left to right, right to left, or whatever it is across my visual field. I have to do a couple things to do that, right? I've got to figure out where the spear is going to be when it gets to the animal. So that has to be accurate. And I have to judge all of that while my eyes and my neck are moving at the same time. So it makes sense that these things are linked. So when the upper neck gives bad information, we can find it in the eyes. We'll frequently see nystagmus. The eyes will move in a very jerky way. Or we'll see a decrease in accuracy to target. That's called smooth pursuit. Smooth pursuit can be measured via ENG or VNG. Those are two diagnostic tests. And you can even measure smooth pursuit neck torsion. So smooth pursuit is your accuracy to tracking the animal. It's not really an animal, obviously, in the medical office, but you're tracking a light. And you can turn someone's head when they have an upper neck problem, and the accuracy goes way, way down. So yes, those things are very much related. KS, yes, also have severe stenosis, C5 through 7, and not much clinical symptoms. So Dr. S told me it to focus on that imaging finding neurologic symptoms, face of head from type 2A and 2B. Yeah, so I think what you're bringing up is important, and we just talked about this, so it's good to bring it back up for everyone's consideration, and that is you've got lower neck issues, and then you've got upper neck issues. If you're only presenting with upper neck symptoms, then that's where we should focus, and we shouldn't be so concerned about your normal degenerative change like everyone has, that's as common as wrinkles. Now, can the lower neck cause symptoms? Absolutely. But we have to have an image and symptoms and then an exam and put all three of those together in order to want to treat that spot. If we just have an image, we don't treat that spot. Rich, ever feel like going on Joe Rogan podcast? He makes a lot of outlandish claims about stem cell treatment, advocates for going south of the border for treatment and downplaying the risk for doing that. Yep. Anyone knows Joe Rogan? Give him my name. Happy to go on his podcast. Melinda, Dr. Centeno, I want to thank you for your care and compassion in educating patients, especially your expertise. Greatly appreciated. Oh, thanks, Melinda. Yeah, it's been interesting now that I've moved this to Sunday morning, right? It impacts my weekend a little bit more. My wife's like, "You're doing what on a Sunday morning? I thought you did that during the week." Having said that, I think hopefully we get more engagement, right? Because, it's very much a mission of mine to educate people. I've written lots of books to educate patients. I write I write blogs all the time to educate patients. I do videos to educate patients. I do these kinds of things to educate patients. And in some ways, that goes back to when I was a medical student. There was a physiatrist, PM&R doctor, René Caillé. He was French, who wrote these fantastic books, and they were kind of for physicians, but they were also for patients. And they had these great drawings in them. And I just found that I got so much out of that because he did such a fantastic job of bringing the complex down to the simple that it really inspired me. And I guess I caught the fever, and I've been trying to do it with my patients ever since. Yep. Thank you. So guys, any other questions I can answer? We're coming right around to the hour mark. Happy to answer last few questions if there are any out there. Looks like yeah, so Jennifer, very common for CCI patients to have shoulder problems. That's why we continuously check those shoulders and those shoulder joints in our patient population. Adore X Angel. I feel like my head is dropping and my head to neck muscles are constantly tearing. I reached out to your clinic today. I believe I have CCI. Would you treat it with surgery or PICL? Yeah, there's a lot more to it than that, right? We would need to get imaging, look at your imaging, get to a diagnosis of which specific ligaments might be involved. Ultimately, we need to do a hands-on exam to better identify what's happening. And then I could make that determination, PICL is appropriate or something else is appropriate, or it doesn't look like CCI, but can't do that online, obviously. Mark, one more question regarding IV stem cell scam. Another claim I see is the online patient groups is lowering the patient's stem cell age. The claim is something like they had the scam IV treatment, healed their injuries, and now they're supposed to have their stem cell age checked out. Sorry about laughing on that one, Mark. No, there's no way that happens at all. That's just some fiction. But it's a hell of a sales technique, right? Shit, you can get IV stem cells, you can cure your medical problems, and then you get younger from the IV stem cells. So no, I don't think that's happening in any realistic way. I don't think there's even a way to accurately measure that. I guess you might look at telomeres in some cells, but there's really no way to measure that. We don't really even know for sure that telomere length necessarily corresponds one-to-one with aging, because some people have shorter telomeres and they live longer. So it's pretty funny. Light Hope, is it recommended to stop collagen and omega-3 supplements 2 weeks prior to PICL? Not the collagen, but certainly omega-3 supplements, especially fish oil, which can cause increased bleeding times. That's an important one to stop for at least 1 to 2 weeks prior to a PICL or any other procedure where they're going to be poking needles around the spine. How can I get in contact with you ASAP? My email address I put up there. You can also reach out to the clinic, either one. Put up there in the comments. Amity Rehab Services, what are the thoughts on Vertos Medical Mild for lumbar stenosis related pain? Does removing a portion of ligament flagellum make sense for long-term relief as they claim? Yeah, so I have mixed emotions about the mild procedure. Dr. Schultz and I trained in it. God, that must have been 10 years ago, something like that. And since then, we've come up with other ways using regenerative medicine to treat stenosis patients that have been pretty effective. I think that if you can't treat stenosis with a specific regenerative medicine technique, for example, injecting high-dose leukocyte-poor PRP into the ligament of flavum and stabilizing the functional spinal unit, then you might want to consider something like mild. But I wouldn't use mild in my practice as a first choice treatment, because it's destructive and will cause more instability once we take that ligament of flavum out. Debbie, what do you do for Parkinson's weak neck? Don't have any solutions for you there, Debbie. Not my area of expertise. Monsef, I had radiculopathy in my right arm and had an MRI, showed herniation C5 to T1 with spinal cord compression. Symptoms have improved, but will my spinal cord compression heal along with the discs? If your symptoms have improved and you don't have any symptoms from this, and you've got normal function, I wouldn't worry about it at all. It's probably time to move on with your life and get stronger and do everything you can. And if it becomes symptomatic again, you'll look at it again. But there's no such thing as that kind of surgery being done just because it looks bad on the MRI. That would be a bad idea, because we'd be exposing you to far too much risk to make an MRI look better, and that doesn't make much sense. Adore, do stem cells cure CCI direct shots? I think what you're asking is, so if you have cranio-cervical instability, can we restabilize the spine? I think we've got good evidence that we can do that. We can also reduce those symptoms from that instability. I don't really use words like cure. If you see words like cure, usually it's a scammy clinic, because there are few cures in medicine outside of antibiotics. So stay away from clinics that use the C word, because we treat problems to increase function and improve stability. But cure means that I made the spot exactly like it was when you were born, and I don't think anyone could ever prove that. Cheryl, can this also cause dizziness after doing things like driving long distances or anything that stresses neck muscles? I have NTOS, or maybe TOS. Yes, cranio-cervical instability can cause dizziness. Yes. Jessica, could see-through retrolisthesis cause CCI similar problems? There has been some report of the C3-4 level also being involved in CCI-like symptom generation, so it could. Beef sticks, do you have an opinion on soft wave therapy prior or post stem cell treatment, especially PICL? I wouldn't waste my money. What are your thoughts on nerve ablation on back? Usually a bad idea. And this has been my last question, because I think we're about 7 minutes over here. So this will be the last question I take today. So what we do, let's kind of just talk about this. So nerve ablation, or radiofrequency ablation in the low back, means that we are killing off the medial branch of the sinovertebral nerve, which is the nerve that innervates or tells the low back stabilizing muscles what to do and when to do it. These are critical muscles for stabilizing your spine. So if I go in, and we did this 20 years ago, we stopped doing it because it was a horrible thing to do to people. If I go in and I kill off that nerve that supplies that muscle, that means that for a year or more, those low back stabilizing muscles that protect your spine are out to lunch. And there's probably some permanent change in their activation pattern, even once the nerve grows back. So we don't want to do that to anybody. Listen, in certain end-stage back patients who need big surgeries and fusions, maybe it's a reasonable thing to do to buy them a couple more years before the fusion. But in my experience, for 90% of the patients that are offered that procedure, it's not a good idea, because you end up with more stability, which causes more wear and tear and more problems. because of the more wear and tear. Okay, guys, very good to see you all here today. We talked today about the concept of a neck pelvis, or all of these joints in here helping to support the head on the neck. Thanks so much for spending the time on a Sunday morning. I appreciate it. And I'll be back this next Sunday morning with something else to talk about. So thanks so much, and have a great week.